Sylvia really needs no introduction, a great friend to our society, one of the founder members of our society, actually, and has been involved in all our guidelines in helping us remain honest. And Sylvia, we're greatly honored and privileged to have you from Germany giving us a talk today on bridging patients in 2020, a practical approach. Thank you very much, Sylvia.
Thank you very much, Barry.
And just to remind you that this talk is sponsored by Sandoz. Thank you.
Thanks a lot. So can you see the slides? I do hope.
Yes, we can. Yes, we can.
Thank you. Well, first of all, I would like to extend a warm welcome from Munich, the place where I work and live. And some of you may perhaps recognize the upper photo in this slide, showing the city of Munich and the Alps in the background. Because I showed it already last year when we had the real meeting in Johannesburg, but the lower photo is a recent one. And this, in fact, is a tribute to the aviator heart of our president, Professor Barry Jacobson. Because this is a photo some month ago when we were in full lockdown and the Munich airport was closed, and you see the Lufthansa aircraft lined up on the apron of the Munich airport, and there was no operation at all. But meanwhile, fortunately, Lufthansa is again operating Johannesburg and Cape Town, and we do hope that this will continue. But now it's all about bridging patients in 2020. These are my disclosures. And I would like to start with the question, what is bridging and why do we need it? Well, in fact, per year, 15 to 20% patients treated with vitamin K antagonists need to undergo an invasive procedure or surgery, which usually necessitates interruption of VKA treatment and therefore increases the risk of thromboembolism, hemorrhage, and death. Bridging describes the replacement of the interrupted vitamin K antagonist with a low molecular heparin until after the procedure. How can we now take the patient treated with warfarin across the perioperative bridge? That is shown in the cartoon here. If we interrupt warfarin, it takes a long time to fade off before surgery, and also a long time to get full anticoagulation when we start post-operatively. So due to the long functional half-life of warfarin, of the interruption without bridging, that leads to a long period without anticoagulant protection. This cartoon shows the theoretically ideal bridging scenario. To bridge the long-acting warfarin, we need a short-acting anticoagulant, that means low molecular heparin, to reduce the perioperative anticoagulation gap. Under special circumstances, INR can be lowered pre-operatively, but this can only be done in minor procedures such as tooth extraction or eye surgery, such as cataract surgery, or any comparable interventions. However, normally we need to put an anticoagulant in between, and that is shown here. If we use full heparin bridging, full heparin bridging means therapeutic dose that, however, may easily lead to over anticoagulation, as again illustrated in this graph. You see the red parts of the anticoagulation therapy are overshooting, and that is again leading to the bleeding risk. This issue was addressed in a recent publication and study already 5 years ago, a randomized double-blind trial comparing low molecular heparin in therapeutic dose with placebo to bridge the anticoagulation gap after discontinuation of warfarin in AF patients. And the last dose of low molecular heparin in these patients, when the INR was low, was then with low molecular heparin 24 hours pre-operatively, and they gave heparin up to 5 to 10 days after surgery until the INR of at least 2 was re-achieved. Here you see the outcome, an increase, significant increase of major bleeding highlighted in the frame, an increase from 1.3% to 3.2%, and the arterial thromboembolism was not different between the no bridging group and the bridging group. That means non-inferiority was achieved, but the bleeding risk was unacceptably high. So the authors concluded, in patients with AF who had warfarin treatment interrupted for an elective intervention, no bridging anticoagulation decreased the risk of major bleeding, so they didn't do anything, and was non-inferior to perioperative bridging with low molecular heparin for the prevention of arterial thromboembolism. So we can summarize and say bridging of warfarin with therapeutic doses of low molecular heparin cannot be generally recommended. That does not mean that we shouldn't do it at all. For example, in patients with artificial heart valves or other very high thromboembolic risks, there is a need to do it in this way, but we can also look for other options as shown in this graph. That means low dose heparin bridging. Lower dose, low molecular heparin bridging, that means half therapeutic dose, reduces the bleeding risk and can be used in patients with moderate thromboembolic risk. That's the way many of our colleagues follow in Germany. And this is also again highlighted and illustrated in this cartoon. There are 3 points we need to consider. We need to do a careful risk assessment regarding thromboembolism and also bleeding. Take into consideration the both thromboembolic risks, why the patient gets anticoagulation therapy, that means, for example, atrial fibrillation or something else, and also the thromboembolic risk of the surgery. We need to inform the patient, then discontinue warfarin, continue INR measurement, and determine the low molecular heparin dose, and also determine the timing of the last dose before surgery. In general, this should be about 24 hours before surgery. So that is an approach much appreciated by our German colleagues. Last but not least, we need to ask the question when we have patients under NOAC therapy, do we need a perioperative bridge for patients with NOACs? This is illustrated in this cartoon. In contrast to warfarin, the NOACs have a rapid on and offset of action, which is comparable to low molecular heparin. Therefore, no bridging therapy is needed. You see the very short gap where no anticoagulation therapy is given when we stop the NOAC before surgery and resume after surgery. Nevertheless, and though not supported by guidelines, many general surgeons, gynaes, and urologists stop the NOACs before surgery and resume anticoagulation with low molecular heparin after surgery before switching back to NOAC. And this is again illustrated in this graph. We stop the NOAC before surgery as shown before, and based on their experience, many of our surgeons prefer then to start the low moles after surgery, be it on the day of surgery in the evening with a prophylactic dose or half therapeutic dose next day. That's up to their decision. And then it's very simple to switch to a NOAC when the hemorrhagic risk is over. So these are my key learnings from today. That means keep the anticoagulation gap as big as needed, but as small as possible, and use bridging of warfarin whenever necessary. Don't use the NOACs for bridging of warfarin, but use low molecular heparin instead, because also this had become a bad habit. Some of our doctors wanted to be very clever and wanted to bridge warfarin with a NOAC. That's not the way to go. If you bridge, please stay with heparin, or in particular low molecular heparin. And with this, I thank you very much for your attention.
Thank you very much, Sylvia. I'd now like to, I see Professor Brenner is back and he is our chairperson. Benny, would you like to come on board? I don't see, he was here a second ago. That's Harry Bueller. There he is. There's Benny's back. Benny, there you are.
Okay.
Benny?
Yeah, I'm here. Can you hear me?
Yes, we can hear. Yes. Do you want to carry on sharing, please?
Okay. So yeah, there is a question from, sorry. There is one question. Thank you very much, Professor Haas. There is a question saying, thanks for a great talk. It's from David Wolfstein. How would you manage a patient with antithrombin deficiency needing a high bleeding risk surgical intervention?
That's an excellent question. Thank you for that. If there is a very severe antithrombin deficiency, of course, the heparins and including the low moles are very difficult. This is very, very rare. In this case, indeed, we would need to look for alternatives. And we perhaps may also say that we need an experienced hematologist. And these are the selected cases where perhaps the NOACs can be very beneficial, but it requires a lot of experience then with the NOACs, how to take the patients across the bridge, because they don't need antithrombin to be active.